Okay, let's unpack this. Imagine the incredible, almost silent dance of the four valves within your heart. The aortic, mitral, tricuspid, and pulmonary. They open and close passively, perfectly orchestrated by pressure and volume changes, guiding blood flow with every single beat.
Right. It's quite amazing when you think about it.
But what happens when that rhythm is thrown off? What if one of these tiny, crucial components malfunctions?
Well, the consequences can be profound, leading to life-threatening emergencies,
Mm,
and they often mimic a host of other conditions, which makes diagnosis tricky.
exactly. So today we're going on a deep dive into valvular heart disease and its complex, sometimes hidden connection to infective endocarditis.
What's truly fascinating here, I think, is how these conditions, often unseen until serious symptoms demand attention, really challenge us in the clinical world.
Yeah.
We've pulled insights from leading medical texts and emergency care guidelines, aiming to give you the most important sort of nuggets of knowledge. Our mission really is to equip you with the understanding of not just what goes wrong with these valves, but why it matters,
Yeah.
and what those critical clues are that you should always be looking for.
Whether you're just intensely curious or maybe you need a quick shortcut to being well-informed for a meeting, get ready for some truly surprising facts and those classic aha moments. We'll cover everything from the whispers of a heart murmur to the really dramatic presentations of acute heart failure, making sure you don't feel overwhelmed, but rather profoundly informed.
Sounds good.
So to kick us off, let's get down to the absolute fundamentals. When we talk about problems with heart valves, we're really looking at two main types, stenosis and regurgitation. Can you walk us through the core difference?
Absolutely. Think of stenosis as a narrowing of the valve. It's like a doorway that won't open all the way.
Okay.
Blood struggles to flow forward through that constricted opening, and that turbulent flow is precisely what creates a heart murmur.
Right. And then there's regurgitation, which you might also hear called valvular incompetence.
Exactly. That's when the valve fails to close properly. Like a leaky faucet, basically.
Okay.
Instead of a smooth one-way street, blood leaks backward, creating a different kind of murmur.
Got it. So these murmurs, they help us pinpoint the issue. You mentioned a murmur clock.
Yeah, it's about understanding when the murmur occurs in the heart cycle. Murmurs are simply the sound of turbulent blood flow. We classify them as either systolic or diastolic.
So systolic murmurs happen during ventricular contraction, right? That's when the heart is actively pumping blood out.
That's it.
What are some of the conditions that cause these?
You'll hear systolic murmurs in conditions like mitral regurgitation, tricuspid regurgitation, aortic stenosis, pulmonic stenosis, or even something like a ventricular septal defect.
Okay.
Conversely, diastolic murmurs occur during ventricular relaxation, when the heart chambers are refilling with blood.
Right.
This is where you might hear aortic regurgitation, pulmonic regurgitation, mitral stenosis, or tricuspid stenosis.
That's a crucial distinction. So what's the biggest takeaway for our listeners when it comes to the difference between systolic and diastolic murmurs?
The absolute critical point to remember, and this is really important, is that while many systolic murmurs can actually be benign, meaning they're not a sign of serious disease, diastolic murmurs are almost always pathological.
Always.
Pretty much always, yeah. If you hear a diastolic murmur, it warrants further investigation. Definitely.
Okay.
And speaking of loudness, we use a grading system, grade 1 to 6. A systolic murmur, that's grade 3 or louder, is usually considered hemodynamically significant.
Meaning it's actually impacting blood flow.
Exactly. Needs
Yeah.
a closer look.
Now let's zoom in on specific valves, starting with the aortic valve, absolutely critical, right, for blood flow out to the body.
Crucial.
First up, aortic stenosis, or AS. How serious is this condition, really?
AS is a restriction in the opening of the aortic valve. It obstructs outflow from the left ventricle, and it's considered severe when the valve area shrinks to 1 centimeter or less.
It's just tiny compared to normal.
It is. Normal is 3 to 4 centimeters first. What's truly chilling about AS is that by the time you see the classic triad of symptoms, breathlessness, chest pain, and exertional syncope, well, the prognosis is actually quite poor without surgery.
Wow.
It's a real race against time once those symptoms declare themselves.
That's significant. So what typically causes this narrowing? Is it the same for everyone?
Not at all. In young adults, it's often congenital, maybe a bicuspid valve, 2 leaflets instead of 3.
Okay.
Worldwide, rheumatic heart disease is a common culprit. But in many Western countries, like the UK, particularly in people over 70, the most frequent cause is age-related degenerative calcific changes.
And that's linked to things like high blood pressure.
Yeah, exactly. Linked to atherosclerosis risk factors like hypertension and smoking.
Can you break down the pathophysiology for us? What's happening inside the heart as that valve narrows?
Well, as the valve narrows, the left ventricle, the LV, has to work incredibly hard to push blood through. This leads to thickening of its muscle that's left ventricular hypertrophy.
Yeah.
Initially, the heart compensates. But in severe cases, it just can't keep up. The muscle becomes stiff, it struggles to fill properly, and that's when you start seeing abnormal function and ultimately pump failure.
So you mentioned the classic triad. What are the critical red flags a clinician should be looking for?
Well, beyond the triad, breathlessness is often the very first symptom you'll notice.
Okay.
On examination, a distinctive pulse is pulsus parvus et tardus. That's a slow-rising, small-volume pulse that feels kind of sustained at its peak.
Right.
When you listen to the heart, you'll hear a harsh systolic ejection murmur, best heard just to the right of the sternum, second intercostal space, and it often radiates right up into the carotid arteries in the neck.
Wow. Okay.
A fourth heart sound, a gallop rhythm, might also be present. Interestingly, as the severity increases, that harsh murmur can actually become softer and more prolonged.
That seems counterintuitive.
It does, but it's a feature of severe AS.
Oh, okay. That's a lot of crucial detail. What are the key management pearls for AS in an emergency setting? Are there any medications we should absolutely avoid?
This is critical.
Yeah.
For pulmonary edema, diuretics and continuous positive airway pressure, CPAP, are helpful.
Right.
But here's the crucial avoidance. Patients with AS are preload dependent. Their heart absolutely relies on a good volume of blood returning to it to maintain output.
So don't reduce that volume.
Exactly. Medications that reduce preload, like nitrates and ACE inhibitors, can cause a sudden and dangerous drop in blood pressure. They are generally contraindicated.
Okay, very important.
If there's chest pain, beta blockers can help by reducing the heart's oxygen demand. And for new onset AF, atrial fibrillation, digoxin can slow the ventricular response and improve stroke volume.
And severe cases.
Ultimately, severe cases with heart failure or cardiogenic shock often demand emergency surgery.
Let's transition to the flip side, aortic regurgitation, AR, the leaky aortic valve. What causes this? Does it differ if it's sudden versus chronic?
Right. AR is when the aortic valve fails to prevent blood flowing backward from the aorta into the left ventricle during diastole, the filling phase. And yes, the causes do differ significantly.
Okay.
Acute AR, sudden onset, is often a true emergency, caused by things like aortic dissection, often with that tearing chest pain. Very. Or infective endocarditis, prosthetic valve dysfunction, or even trauma like a ruptured leaflet.
And chronic.
Chronic AR develops over time. Can be due to calcific degeneration, enlargement of the aortic root, rheumatic heart disease, or connective tissue disorders like Marfan syndrome, even autoimmune diseases.
So how does the heart respond differently to a sudden leak versus a long-standing one? What's the pathophysiology?
Well, regurgitation leads to volume overload in the left ventricle. In acute AR, the LV simply doesn't have time to adapt.
Okay.
This causes a sharp, sudden rise in LV pressure and quickly leads to acute heart failure. It's an emergency.
Right.
But in chronic AR, the LV progressively dilates and hypertrophies over years to compensate, so patients can tolerate it for a long time without symptoms.
The heart adapts.
It's actually quite clever how it adapts. Interestingly, a faster heart rate, tachycardia, actually helps reduce the regurgitant volume in chronic cases. Sort of counterintuitive again, maybe?
That adaptability is amazing.
Yeah.
What are some of the dramatic clinical features we might see with AR? I've heard about some very visual signs.
Indeed. Patients often report palpitations, chest pain, fatigue, or signs of heart failure. On examination, a classic finding is the water hammer pulse, a pulse that rises rapidly and then collapses very quickly at a wide pulse pressure. Some of the visually striking signs, though maybe less common now with earlier diagnosis, include Corrigan sign, visible carotid pulsation.
You can see it?
Yeah. Traub sign, a pistol shot sound over the femoral artery, and Quincke's pulse. We can see capillary pulsations in the fingertips.
Wow. Okay.
Pretty dramatic stuff.
And what about the murmur itself? Are there any diagnostic pitfalls for AR?
You typically hear a soft, blowing, early diastolic murmur, best heard with the patient leaning forward, holding their breath out.
Yep.
In severe AR, you might also hear an Austin Flint murmur at the apex. But here's a crucial pitfall, especially for acute presentations. That typical blowing diastolic murmur might be soft or even absent in acute severe AR
Why is that?
because of rapid pressure equalization across the valve. So it's easily missed in the chaos of an emergency department. Don't rely on hearing it.
Got it. That's a key takeaway. Given that, what's the critical emergency management for acute severe AR, and what are the absolute do-nots?
Acute severe AR is a surgical emergency, full stop. Management focuses on reducing pulmonary venous pressure and increasing cardiac output, often using vasodilators like nitroprusside, maybe intubation, positive pressure ventilation, and inotropic support to boost heart contractility.
And the don'ts.
Right, what to avoid. Nitrates and diuretics have little effect in acute severe AR. The intra-aortic balloon pump is contraindicated.
Oh, contraindicated.
Because it inflates during diastole, which would actually worsen the regurgitation. It makes the leak worse.
Okay, makes sense.
Also, avoid beta blockers. They can inhibit the helpful compensatory tachycardia and increase diastolic filling time, again, worsening the AR.
Okay.
For acute presentations of chronic AR, the focus shifts to adjusting medical therapies like diuretics, vasodilators, and controlling rate and rhythm. And it's worth noting, patients with AR have an increased risk of developing infective endocarditis.
Okay, having explored the challenges of the aortic valve, our journey now takes us to the mitral valve. Different problems, but just as critical. Let's start with mitral stenosis, MS-RED, the restricted gait.
That's a good analogy, yeah. Mitral valve narrowing restricts blood flow from the left atrium into the left ventricle, impairing LV filling.
And symptoms only show up when it's pretty severe.
Often, yeah.
Yeah.
Symptoms usually don't appear until the valve area is significantly reduced, maybe down to 1 to 1.5 centimeters or so. Normal is 4 to 6 centimeters or so.
Wow. And the cause, still rheumatic heart disease.
That's still the commonest cause worldwide.
Yeah.
Other causes are less frequent, but include infective endocarditis, calcification of the mitral annulus, or even a left atrial myxoma, a type of heart tumor.
And what's happening inside the heart with this restricted gait? The pathophysiology.
Well, the obstruction to atrial emptying leads to increased pressure in the left atrium and the pulmonary veins. This causes the left atrium to enlarge.
Yeah.
This high pressure can then lead to reduced lung compliance, which is why people get breathless. If severe enough, it can cause reactive pulmonary hypertension.
Affecting the right side.
Exactly. Strains the right side of the heart, potentially leading to right ventricular hypertrophy and failure. And atrial fibrillation, AF, which is common in MS, further impairs LV filling because it eliminates that atrial kick.
Right, that final squeeze from the atrium.
Precisely. It's important for filling.
So what are the classic clinical features patients might experience? And are there any subtle clues or diagnostic pitfalls here too?
Exertional breathlessness is often the first symptom. Patients might also experience orthopnea, difficulty breathing lying flat, or paroxysmal nocturnal dyspnea, waking up breathless at night.
PNDA, yeah.
AF, pulmonary edema, even hemoptysis, coughing up bloods can occur. You might even see a distinctive mitral facies, those pink or purple patches on the cheeks from reduced cardiac output.
Interesting.
The pulse is often small volume and can be irregular due to AF. Diagnosis can be tricky, though. Symptoms can be subtle, mimic other things like COPD.
Leading to delays.
Yeah, delayed diagnosis. And the slow progression often means patients unknowingly reduce their activity levels, kind of masking the severity until a trigger occurs.
That's a great insight about the gradual compensation. So what triggers a patient with MS to suddenly get much worse?
Basically, any situation that increases cardiac output, like exertion, emotional stress, fever, infection, even pregnancy. These can suddenly precipitate symptoms.
Okay.
Or if they develop tachycardia, particularly new onset AF with a rapid ventricular response, that loss of the atrial kick significantly reduces LV filling, and they can crash pretty quickly.
So in the emergency department, what's the game plan for managing MS?
The immediate focus is treating any underlying infection, if you suspect one, using diuretics for pulmonary congestion, and critically controlling the heart rate in rapid AF.
Slow it down to allow filling.
Exactly. Medications like beta blockers, digoxin, or calcium channel blockers help allow better ventricular filling. Anticoagulation is also key for MS patients with AF or a prior clot, usually with warfarin.
Okay.
If cardioversion is considered, you have to be really aware of the high risk of atrial thrombus, clots in the atrium, and potential embolization.
Right.
Definitive treatment often involves urgent balloon mitral valvuloplasty, Stretching the valve open is a first-line therapy for critically ill patients, though surgery, repair, or replacement might be needed if that's not suitable.
You also mentioned distinguishing between rheumatic and non-rheumatic MS. What's the key difference there?
Right, that's important. Non-rheumatic calcific MS is an age-related degenerative thing. Calcification of the mitral annulus extends into the leaflet bases. Unlike rheumatic MS, there's no commissural fusion. The leaflets aren't fused together at their edges, and the tips are usually unaffected. Assessing its severity is difficult, and interventions are generally reserved for highly symptomatic patients due to increased risks.
And prophylaxis for endocarditis in MS?
Generally, routine antibiotic prophylaxis for infective endocarditis is not routinely recommended for most native valvular heart disease, including MS. That's a change from older guidelines.
Okay. Now, let's explore the opposite problem for the mitral valve. Mitral regurgitation, MR, the backflow issue. Can this be an emergency?
Absolutely. Mitral regurgitation, the backflow of blood from the LV into the LA during systole, can definitely be a cardiovascular emergency.
Especially acute MR.
Yes. Acute MR is often due to a ruptured chordae tendineae or papillary muscles. This can happen after a heart attack, which is itself an emergency with high mortality if untreated quickly. Or trauma, or, importantly, infective endocarditis again. Chronic MR can be due to rheumatic heart disease, LV dilation from ischemia or cardiomyopathy, or myxomatous degeneration, sort of floppy valve tissue.
So when blood suddenly leaks backward, what's the immediate impact?
Pathophysiology.
During systole, blood regurgitates back into the left atrium. This causes a sudden drop in the amount of blood pumped forward, the cardiac output, leading to rapid onset of pulmonary edema.
Especially in acute MR.
Especially in acute MR, yeah, because the left atrium hasn't had time to adapt and enlarge. You can sometimes even see unilateral pulmonary edema, often on the right side, which is a bit unusual.
Clinically, what should we be looking for in a patient with acute MR? And are there any diagnostic traps here too?
Patients with acute MR are typically acutely unwell. Severe breathlessness, pulmonary edema, often with a rapid heart rate, tachycardia.
Okay.
And here's a diagnostic pitfall. In acute MR, the classic pansystolic murmur might actually be difficult to hear.
Was that due to the very high heart rates, noisy environments, or sometimes just the direction the regurgitant jet is pointing?
So, lack of a loud murmur doesn't rule it out.
Absolutely not. Don't assume the absence of a loud murmur means the problem isn't severe in an acute setting.
Got it.
In chronic MR, the LA and LV have adapted, enlarged, thickened over time, so they tolerate it much better. When you do hear the murmur, it's typically pansystolic, radiating to the axilla and back. You might hear a third heart sound, too.
And for emergency management, is surgery the only answer, or are there temporizing measures?
The definitive treatment for acute MR is operative surgery, repair, or replacement.
But while waiting?
Temporizing measures are crucial. Positive pressure ventilation, afterload reduction, reducing the resistance the heart pumps against, maybe with nitroprusside or nicardipine, and inotropic support like dobutamine to boost contractility.
Okay.
Interestingly, the intra-aortic balloon pump may actually benefit patients with cardiogenic shock due to acute MR, unlike in AS.
Right, you mentioned that distinction.
And of course, treating the underlying cause, like an acute MI, is paramount. For acute presentations of chronic MR, that's often related to AF onset, so therapy aims to reduce afterload and control the AF.
Finally, for the mitral valve, let's quickly discuss mitral valve prolapse, MVP, the floppy valve. Does this need emergency attention?
Mitral valve prolapse is when a portion of the valve leaflets kind of bulges back into the left atrium during systole, usually with just a small amount of regurgitation.
And it's common.
It's quite common, yeah. Found in 2–5% of the population, more often in women. Pathophysiologically, it involved these fibromysomatous changes in the leaflets.
Symptoms?
Most patients are actually asymptomatic. If symptoms occur, they can include atypical chest pain, palpitations, breathlessness. The characteristic finding on auscultation is that mid-systolic click.
The click.
Yeah, a high-pitched sound from the sudden tensing of the valve as it prolapses. Generally, acute treatment for MVP is rarely needed in the emergency setting.
So the ED role is mostly exclusion.
Pretty much. Rule out other acute causes for the symptoms. Patients are typically referred for outpatient follow-up.
Okay. Now let's shift our focus to the right side of the heart, specifically tricuspid regurgitation, TR. What causes this? What are the implications for the right side?
Tricuspid regurgitation is insufficiency of the tricuspid valve. It can be congenital, like an Ebstein's anomaly, but the most common acquired causes are due to the right ventricle dilating.
Dilating from what?
From other conditions, like mitral valve disease putting strain back on the right side, or right ventricular infarction, or pulmonary hypertension.
Okay.
It's also very commonly associated with infective endocarditis, particularly in IV drug users, and can be seen in Marfan syndrome too.
So when does TR become clinically apparent? What are the symptoms?
Patients with TR are often asymptomatic until right heart failure actually develops. Then you start seeing things like peripheral edema, swelling in the legs, a site that's fluid buildup in the abdomen from liver congestion, and maybe generalized abdominal pain. And as we mentioned, IV drug users might present acutely unwell with staph endocarditis affecting the tricuspid valve.
And on exam, pulse, JVP.
Atrial fibrillation is common, and you might observe large phase waves in the jugular venous pulse, a specific pattern of pulsations in the neck veins indicating backflow into the atrium.
And for auscultation, are right-sided murmurs tricky to pick up?
Yes, they can be a pitfall. You'll hear a soft pansystolic murmur at the left sternal edge, which typically gets louder on inspiration.
Ah, the inspiration helps differentiate.
It's a helpful sign, yeah. A third heart sound is also often present, but the key pitfall is that right-sided murmurs are often soft and can be easily missed in a noisy ED.
So how do we manage TR, especially when infective endocarditis is involved?
Management for TR is primarily targeted at treating the underlying cause. If it's tricuspid endocarditis, especially in an IV drug user, aggressive antibiotics covering staph are crucial, and early surgery might be needed.
Moving on, we need to talk about prosthetic valve emergencies. When artificial valves malfunction, what are the main types and what's the big trade-off?
Right. Two main types: mechanical valves and bioprosthetic or tissue valves. Mechanical valves are incredibly durable, last a long time, but they come with a significant trade-off. They require lifelong anticoagulation, blood thinners, to prevent clots. And the target level, the INR, can differ depending on the valve position.
Okay. And bioprosthetic?
Bioprosthetic valves, made from animal or human tissue, are less likely to cause clots, so less need for long-term anticoagulation. But they're less durable. They wear out over time and often need repeat surgery.
So considering those trade-offs, what are the big three complications of these artificial valves we need to be acutely aware of?
Number one is thrombosis and thromboembolism, blood clots forming on the valve or breaking off and traveling.
Especially with mechanical valves.
Especially with mechanical valves if anticoagulation isn't adequate. Highest risk in the first 3 months after surgery. These clots can cause acute regurgitation, stenosis, systemic embolization like a stroke, or even sudden death.
Any clues on exam?
A subtle but crucial clue for a mechanical valve clot is a reduced or absent crisp clicking sound when listening. The normal click might be muffled or gone.
Okay. Complication number two?
Number two is infective endocarditis, a significant risk, up to 6% within 5 years, and carries high mortality. Early infections within 2 months post-op are often from wound contamination or lines. Later infections are caused by the usual suspects that infect native valves.
And number three?
Number three is outright mechanical failure, sutures coming undone, gradual degeneration, or even a sudden fracture of a component. Acute failure can present dramatically. Acute respiratory distress, pulmonary edema, cardiogenic shock can lead to sudden death.
That's incredibly important to know. How do we handle these as emergencies?
Any acute prosthetic valve dysfunction is a medical emergency. Requires urgent consultation with cardiology and cardiothoracic surgery immediately.
Okay.
Emergency surgery or thrombolytic therapy, clot-busting drugs, may be needed in severe cases. Aspirin therapy is also recommended for all patients with prosthetic valves.
What about bleeding complications from the anticoagulation?
Right. If there's acute bleeding from excessive anticoagulation, the warfarin should be reversed, usually with vitamin K or clotting factors, in consultation with hematology. Then heparin bridge and restart warfarin when stable.
And if you suspect endocarditis on the prosthetic valve,
Need immediate blood cultures, start broad-spectrum antibiotics right away and get an echocardiogram. Usually a T is preferred for prosthetic valves.
and that leads us perfectly into our final overarching threat that we've touched on throughout. Infective endocarditis, i.e., you mentioned it involves vegetations. Can you explain what those are?
Right. Infective endocarditis is an infection involving the endocardial surface of the heart, including the valves. Its hallmark is the formation of these vegetations.
Which are?
Essentially a clump, a thrombus, a small clot that has been colonized by bacteria or fungi. It's a mix of clot, bacteria, and inflammatory cells. While its prevalence is low overall, it's a devastating disease if left untreated.
So who's most at risk for developing IE? And why is intravenous drug use such a major factor here?
Major risk factors include pre-existing heart valve disease, whether native or prosthetic, structural heart disease like congenital defects or rheumatic heart disease. A history of previous IE is a big one too.
And IV drug use.
Intravenous drug use, IVDU, is a major increasing risk factor. It boosts the incidence dramatically, like 30 to 200-fold, and it very frequently affects the tricuspid valve on the right side.
Why the tricuspid?
Because that's the first valve encountered by bacteria injected into the venous system. Other risks include pacemakers, hemodialysis, poor dental hygiene, HIV.
What are the common bacteria causing this infection?
Overall, the most common culprit is Staphylococcus aureus, especially in IV drug users and early prosthetic valve infections. For infections after dental procedures, think Streptococcus viridans. For prosthetic valves, Staph aureus again, and also coagulase-negative Staphylococcus epidermidis.
And how do these terrifying vegetations actually form inside the heart? What's the process?
It's a multi-step process, really. First, you need some endothelial damage, often from turbulent blood flow over an abnormal valve. This creates a rough spot.
Right.
Platelets and fibrins stick to this damaged spot, forming a little sterile thrombus. Then, if bacteria get into the bloodstream, bacteremia.
From IVDU or dental work or whatever.
Exactly. Those bacteria can then colonize this thrombus. This colonization triggers more fibrin and platelet aggregation, building up this infected mass, the vegetation.
And they can break off.
That's the danger. They can constantly shed bacteria into the bloodstream, causing persistent infection, and they can embolize, break off, and travel to distant sites in the body, causing problems there.
That helps explain why the clinical features are so variable and challenging to diagnose. What are the key symptoms? And what are those surprising clues outside the heart that often get missed?
Yeah, IE is notoriously difficult, a real chameleon. Systemic symptoms are common. Fever is the big one, present in 80–90% of cases, most consistent feature. Chills, malaise, fatigue, anorexia, weight loss, muscle aches, headache.
Standard infection signs.
Pretty much. Then cardiac manifestations. A new or worsening heart murmur up to 85% of cases, but maybe not initially. Acute heart failure, valve rupture, cardiac abscesses, conduction problems.
Okay. But the really tricky part is the embolic stuff.
Absolutely. Embolic complications occur in nearly half of patients and are truly critical clues that can hide the diagnosis or be the presenting feature.
So a fever is a big one, but what are some of those unexpected signs that should make us think of IE, even if the heart seems okay initially?
Right. Think neurologic complications,
Yeah.
like a stroke. A stroke in a young patient with a fever or an IV drug user screams possible, i.e. until proven otherwise.
Okay.
You can also see brain abscesses, cerebral hemorrhages, or mycotic aneurysms, those infected bulges in blood vessels that can rupture. Terrifying. For right-sided endocarditis, common in IVDU, you might see septic pulmonary emboli. They can mimic pneumonia or a standard PE.
How do they look different?
Often show up as multiple cavitating nodules, little holes or cavities on imaging. Can cause cough, hemoptysis, pleuritic chest pain. Other emboli can hit the kidneys, spleen, joints, intestines, cause acute limb ischemia.
And those classic peripheral signs, Osler's nodes, Janeway lesions.
Yeah, the classic peripheral signs are less common now with earlier treatment, seen in maybe less than 5%. But still important historical clues. Roth spots in the eyes, painful Osler's nodes on finger or toe pads, painless Janeway lesions on palms and soles, splinter hemorrhages under the nails. If you see them, think IE.
Given this incredibly varied presentation, what's the absolute single most important test if we suspect IE?
The single most important test is blood cultures. No question.
How many?
Obtain at least 3 sets from different sites before starting antibiotics, even if it causes a slight delay, because the bacteria in the blood in IE is generally constant, not intermittent.
Okay, 3 sets before antibiotics and echo.
Echocardiography is the other cornerstone of diagnosis. Absolutely essential.
And how do the different types of echo play into that? TTE versus T.
Right. Transthoracic echo, TTE, the one done on the chest wall, is the initial screening tool. It's about 65–70% sensitive for native valve, i.e., maybe only 50% for prosthetic valves. Can miss small vegetations or be limited by patient factors.
So if TTE is negative or unclear,
then you go to transesophageal, echo, TE. The probe goes down the esophagus, gets much closer to the heart, much higher sensitivity, 90–96%. Preferred for prosthetic valves when TTE is inconclusive or when you suspect complications like an abscess.
Can T rule it out completely?
Not absolutely. A negative T doesn't completely rule out IE, especially very early in the disease, but it's our best imaging tool.
Okay. Other tests, labs, imaging.
Other labs, like a complete blood count, Inflammatory markers like CRP and ESR, they'll likely be high, but they're nonspecific. Urinalysis might show blood if the kidneys are involved. Imaging like a chest X-ray might show pulmonary edema or those multiple infiltrates in right-sided, i.e. MRI for suspected brain involvement.
And how do clinicians put all these pieces together for a diagnosis?
Diagnosis is guided by the modified Duke criteria. It's a scoring system. Combines major criteria like positive blood cultures with typical organisms or echo evidence of endocarditis, like a vegetation or abscess, with minor criteria.
Minor criteria
Like a predisposing heart condition or IV drug use, fever, those vascular phenomena like emboli or Janeway lesions, immunologic phenomena like Osler's nodes or Roth spots, or suggestive blood cultures that don't quite meet major criteria. You need a certain combination to make the diagnosis definite or possible.
Got it. Once diagnosed, what are the overarching principles for managing IE?
First, emergency stabilization, ABCs. Treat acute complications like heart failure or sepsis immediately.
Then antibiotics.
Then, broad-spectrum empiric antibiotics should be started after those crucial blood cultures are obtained. Something like vancomycin plus cefepime or ceftriaxone might be typical initially.
And it's long-term treatment.
Oh yeah. Prolonged intravenous therapy is essential, typically 4 to 6 weeks for native valves, maybe 6 to 8 weeks or longer for prosthetic valves. Therapy is then tailored to the specific bacteria identified from the cultures and their sensitivities.
Okay.
And it's important to know that persistence of fever for a few days or even occasional ongoing emboli doesn't necessarily mean the antibiotic treatment isn't working. It can take time.
And when does it become a surgical emergency? You said over half might need surgery.
Yes, surgery plays a huge role. Urgent surgery, meaning within 24 hours, is indicated for patients with severe heart failure or cardiogenic shock caused by the IE, like acute severe aortic regurgitation, severe prosthetic valve dysfunction, or a fistula, a hole into a heart chamber.
Okay. And slightly less urgent surgery.
Surgery within a few days is recommended for persistent heart failure despite medical therapy, signs of poor hemodynamic tolerance, valve obstruction by a large vegetation, abscesses around the valve, or a large vegetation, say, over 10 millimeter, especially if they've already caused embolic events, trying to prevent further emboli.
Any crucial considerations for surgery, especially IV drug users or post-stroke?
Yes, vital points. Surgery is generally not indicated for IV drug use-associated IE unless absolutely necessary for survival, because the risk of reinfection and recurrence is just so high.
Right.
Also, if a patient has had a stroke due to IE, surgery should ideally be delayed. Maybe 1 month after a non-hemorrhagic stroke, and 4 weeks after a hemorrhagic stroke, because operating earlier carries a high risk of worsening the neurological damage.
Okay, that's critical timing. Finally, what's the current thinking on antibiotic prophylaxis for IE, preventing it in the first place? I know this has changed.
It has changed significantly, yeah. Routine antibiotic prophylaxis before invasive procedures, like most dental work, is no longer recommended for most patients by current guidelines, like NICE in the UK.
No longer routine. For who is it still recommended?
It's reserved now for only the highest risk groups. That includes patients with prosthetic heart valves, patients with a prior history of IE, or certain complex congenital heart conditions.
And only for certain procedures.
Yes, typically reserved for high-risk procedures involving active infection or significant manipulation of gingival tissue or the tooth root, where significant bacteremia is likely. Not for routine fillings or checkups for most people.
Okay, that's a much more targeted approach now. So what does this all mean? We've just navigated the intricate and sometimes hidden world of heart valves and their malfunctions. From subtle stenosis to dramatic acute regurgitation. We've also explored infective endocarditis, understanding how something like a fever or even a stroke can be critical clues to this deeper underlying cardiac infection. It's clear these conditions are complex, but recognizing the patterns, knowing what to look for, it can be truly life-saving, can't it?
Absolutely. And if we connect this to the bigger picture, it really highlights the body's incredible ability to compensate, often silently, for years sometimes, until a tipping point is reached. Then you get those dramatic acute presentations.
Right.
Which raises an important question, I think, for you, our listener. Next time you encounter an unexpected heart murmur, maybe, or hear about a patient with what seems like a fever of unknown origin, how might understanding these complex cardiac conditions shift your perspective? How might it prompt deeper inquiry into the underlying why?
That's a great point. We hope this deep dive has given you a clearer understanding of these critical cardiac conditions, offering you those key details and maybe some aha moments that make you feel truly well informed.
Hope so.
Continue your deep dive into the fascinating world of internal medicine.